Now, welcome back to all of you. The next very important topic, forget about entrance. VT is one topic you need to be very sure as a good medical student. Anytime any patient, even in a bus stop, can go into ventricular tachycardia. You must know how to minimally manage a patient. And of course, as a house surgeon, giving an electric shock cardioversion on a VT, VF, they are the part of the basic and advanced life support. You need to be very sure. Now doc, any entrance you take, out of 30 questions in medicine, at least 5 questions are from cardiology. Out of the 5 questions in cardiology, 1 will be on one of these 4 arrhythmias. SVT, VT, atrial fibrillation, WPW syndrome, Torsades de Pointes. You need to be 100% sure. And I am here to make you that. Now doctor, what are the causes of VT? Very commonly heart attack, acute MI. Cardiomyopathy, any chronic ischemic disease. Now, a VT can lead to hemodynamic compromise. A VT can convert into ventricular fibrillation, ultimately lead to development of cardiac arrest. So, what is a typical ECG strip? A unmistakable strip of VT. A wide QRS complex arrhythmia with a fast heart rate is equal to VT. Forget whether it is SVT with aberration, that is a DM cardiology level. But wide QRS complex with a fast heart rate, if you can't recognize as a VT, we are failing to prepare you for good housemanship. Abnormal automaticity or a triggered activity in a ischemic tissue or a scarring of the ventricular tissue due to infarct, where there is a re-entry pathway, any of this can initiate the VT. Patients can have palpitations, syncope, low cardiac output, anything is possible. ECG will show an abnormal QRS complex with the rate more than 120 per minute in case of the VT. VT should be differentiated from SVT with an aberrant conduction. So, what are the features? You are a house surgeon managing a case of broad complex tachycardia in a patient, elderly man, paraded to you, doctor. How do you say it is VT? Any history of MI, because MI can lead to a scar in the heart. MI can lead to a re-entry pathway. So, history of MI favors VT instead of SVT. Any AV dissociation, atria are marching at their own speed, ventricle is marching at their own speed. AV dissociation, if you can see, favors to VT. If they are capture beats or fusion beats, they are pathognomonic of VT instead of SVT. Any extreme left axis deviation, how do you know there is left axis deviation? Directly looking at ECG, doctor, it's very simple. Lead 1, lead 3. If the lead 1 is QRS upright, lead 3 is QRS down. They left each other. If the lead 1 QRS is down, lead 3 QRS is up. They are right towards each other. So, looking at lead 1 and 3 only, you can decide left axis or right axis. If left axis deviation is there, more so it is in favor of VT. Then very broad QRS. How broad? More than 140 milliseconds. And if it is SVT, before your cardiologist comes, can a house surgeon control the rate of an SVT? Simple. Just to stand on the side of the neck of the patient and start doing carotid massage. It will stimulate the vagus and that leads to control of the SVT. But don't do on both the carotids at the same time. Before cardiologist comes, patient will die. So, in spite of carotid sinus massage, there is no response. It is more in favor of VT. There are some clinical clues. Then ECG wise, quickly tell me, what are the clues that will point the finger towards, very good, towards the VT versus SVT? VT is more likely, first look at QRS, more than 0.14 seconds. AV dissociation, it is more likely to be VT. A bifid upright QRS with the tallest peak in the V1, right sided lead, or if there is a deep S wave in the V6, left sided lead. If there is a concordant QRS direction, that is the same polarity of the QRS complex in all the chest leads, V1 to V6, they are all in favor of VT instead of SVT. So this is a typical ECG, doctor. What you have is a broad complex QRS more than 0.14 and a regular rhythm, and P wave is either absent or it is not at all related to the QRS. It is here you have a P wave, then you have a QRS, then there are P wave need not always be accompanied by QRS, AV dissociation. Now another challenge for the VT is idioventricular rhythm. It is also called slow VT. Have you seen any patient who had MI in the ICCU? Classically you will find idioventricular rhythm in ischemic patients. When they are recovering from MI, there will be a slow VT which will be occurring but with a rate less than 120. When do you call VT? If the rate is more than 120, you call it as VT, but it is less than 120. And why does it occur when the patient is recovering from MI? You have given a thrombolytic agent or you have done a coronary angioplasty with a stent. When you have reperfused the heart, it brings a lot of free radicals, and those free radicals act like an excitotoxins and initiate a idioventricular rhythm in a recovering myocardium after MI. So there you find a slow VT which is called as idioventricular tachycardia is what need to be remembered. Generally, these episodes of idioventricular rhythm are all self-limiting and asymptomatic and they do not require the treatment is what you need to remember. So here what you are seeing is basically called as a slow VT, idioventricular rhythm, which you need to be very sure. Then already you know how to differentiate VT from SVT with aberrant conduction, VT versus slow VT. Then one more entity you need to know, normal heart VT, it is called as. Occasionally people who have a healthy heart, they come in abnormal automaticity at the right ventricular outflow tract. The right ventricle opens mouth into the pulmonary artery, there can be abnormal automaticity. Similarly, one of the fascicles of the left bundle branch also can develop abnormal automaticity, which is the source of VT in a structurally normal heart. That's called normal heart VT. Generally, prognosis is good, and what you need to do is a catheter ablation, which is considered to be curative, is what need to be remembered. So, how do you clinically manage VT? One of the common MCQ in the exam. Synchronized DC cardioversion is the treatment of choice. No other thought. If the systolic BP is less than 90, patient is hemodynamically immunocompromised, synchronized DC cardioversion is the treatment of choice. Suppose he is not hemodynamically tolerated, then intravenous imidazole can be given as a bolus followed by a continuous infusion. You can also use intravenous lidocaine. But what is the problem with lidocaine? It can depress the left ventricular function, leading to acute left heart failure and hypotension. And if there is a hypoxemia, correct it first. Hypokalemia, correct it first before lidocaine. Hypomagnesemia, correct it, because hypomagnesemia, hypokalemia, hypoxemia plus lidocaine is equal to hypotension and congestive heart failure. That's the reason you need to be careful. Beta blockers, they will decrease the automaticity in case of the VT. Imidazole, you can add it if you want an additional control. And which is the agent which you never want to give, you don't want to give, you hate to give? Which drug, which class in VT? Class 1C antiarrhythmics. Examiner, since it is such a sure point you need to know, examiner will definitely put it in one of the options. Class 1C can be given true or false. You must be answering correctly. 1C should not be given, especially when VT is occurring in the backdrop of ischemic heart disease or heart failure, because it will depress the myocardial function. And if there is a very high risk of sudden cardiac death due to VT, that is, suppose if a patient has a poor left ventricular function with VT, or if there is a VT with a low BP, such people implantable cardiac defibrillator is basically recommended. So that's all the story of ventricular tachycardia, which you need to be very sure about, doctor. Now let us take up the last topic for the today's evening before we go to the next part of our quiz, which you have left far behind. So, ventricular fibrillation. VT is over now. Ventricular fibrillation now. You have to be very sure. 5 to 6 points are important. Rapid irregular ventricular activation with no mechanical effect is VF. That means, in spite of a rapid heart activity, there is nothing pumped out. That's called as VF. Patient is pulseless because heart is unable to pump anything at all. It is like heart is getting seizures. It is unable to pump anything at all. And patient become rapidly unconscious. Respiration will stop if you don't aggressively jump and treat the patient, and that lead to cardiac arrest. How is the ECG in this patient? Shapeless, rapid oscillations like a seismic activity on an earthquake day is the ECG graph of the ventricular fibrillation. And it is a ventricular ectopic beat which is the provoking factor for this ventricular fibrillation. See, doctor, this is the VT, classical ventricular tachycardia's broad QRS complexes. The moment they become ventricular fibrillation, what you have is a shapeless contour is what you come across. The only way to treat the ventricular fibrillation is defibrillation. And you need to give airway, breathing, circulation, basic and advanced life support. Suppose if a patient had MI, in the first 1 or 2 days of an acute MI, if there is an attack of VF, then such a patient, you have done defibrillation, patient recovered, but since this episode happened, does he need to receive lifelong prophylaxis against arrhythmia? No. If at all the VF happened in the first 1 to 2 days after the MI, he does not need a long-term prophylaxis. And if the VF happened without any background of MI, such people require prophylaxis because they are at a high risk of developing the sudden cardiac death. So in summary, the favorite question of the examiner is what is the indication of an implantable cardioverter defibrillator? Those who are at the high risk of sudden death. Suppose if there is any acute MI, severe metabolic disturbance, without any such risk factors, in the absence of them, if there is any VF, such people are at high risk of sudden death. You need to put a implantable cardioverter defibrillator as a first line therapy, as what you can see, which will be ready. Any time there is a VF, it will defibrillate and then restore the normal rhythm. Now, in this context, you need to know what is meant by Brugada syndrome. 2 to 3 points you need to know. There is no structural cardiac disease, doctor. A patient presents with an idiopathic VF. In such people, you should think of the possibility of what is called as Brugada syndrome is what you need to know. So we belong to India. India is what? Southeast Asian country, na? SAARC. So Indians, young male adults are the high risk of Brugada. And how do you diagnose it? Typically, if you give class 1 antiarrhythmic like flecainide, then it will initiate a right bundle branch block with a coving ST elevation in the V1 to V3. If you give flecainide, that's how you recognize the Brugada syndrome, which is a case of idiopathic ventricular fibrillation in India. So what are the important 3 features in Brugada syndrome, doctor? Prolonged PR, right bundle branch block. How do you know this is right bundle branch block? Look at lead 1 and lead 3. If the lead 3 is pointing up, lead 1 is pointing down, they are right towards each other. It is called right bundle branch block. And there is an ST segment elevation. What kind of ST segment elevation? Coving type of an ST segment elevation, as what you can see, is called as Brugada. So there are 3 types of ST elevation, doctor. Coving means this. Saddle back means this. And these 2 are saddle back, this is coving. Coving is more classical of Brugada syndrome. So why these people are developing idiopathic VF and why there is a coving type of an ST segment elevation? What is the underlying pathophysiology in Brugada? It is a channelopathy. Loss of sodium channel function is the underlying cause. But why are we worried about this? They are at the risk of developing sudden death during sleep. And they are at the risk of cardiac arrest and syncope. And the only successful treatment is placement of ICD. And in these people, can we give beta blockers like others? No sir, it is not helpful. And it can be harmful is what you need to ultimately remember. So that brings us to the end of today, our planned list of topics. One more topic was there, SVT, with which we would have said goodbye to cardiology for us to start afresh the neurology. We'll do one thing, tomorrow Saturday subject test is there, 2 to 5. Instead of that subject test discussion, let us initiate neurology. Because for the past 2-3 days you had been listening to endocrinology. I don't want to repeat endocrines, so we can go ahead with neurology. What do you say? So tomorrow we'll skip the subject test discussion and take up the neurology, neurology discussion. That's good. Now let us take up the remaining part of the quiz discussion. Just 10 more questions, we will finish that. What was the last question where we were there, doctor? Just 10 more questions. Yeah. Hope. Deva 21, that's right. Deva, Jasmeet, Vinod, Fahima, Nina, you're all online. I'm happy to know that. So you need to quickly shoot the answers for us to finish the remaining, I think 15 more questions. What findings favor a supraventricular origin of a wide QRS? Now you have to answer. Now you have finished your DM cardiology, no? Yes. What is except about it? Which is except, which doesn't favor supraventricular but favors ventricular. Which one? Which is the finding? Question number 21. Already we have discussed this point. Do you like to say triphasic QRS complexes or a ventricular rate more than 170 or the QR or QS complex in V6? What did you remember in our last discussion? Question number 21. You need to shoot me one confident and a quick answer, doctor. Yes, that's good. More than 0.14 second means it favors VT. Less than 0.14 means it favors SVT. So no objection about D. Question number 21. You need to wake up from the sleep and answer, doctor. That's good. QR or a QS complex in V6. It is more in a favor of a VT. That's what we discussed in a. No. Deva thought it as D. More than 0.14 is VT, doctor. 0.122, 0.14 is SVT. So D is not the answer. Except is C, which is QR or QS complex in V6, which is in favor of which is in the favor of VT. How many seconds? This I think most of you will correctly answer. How many seconds if the VT is continuing, you call it as sustained? Less than how much you call it as non-sustained? Who will give me the correct answer? Question number 22. Yes. How do you differentiate sustained, non-sustained VT? One confident answer please. Is your lucky number is 10 seconds, 30, 60 or 120 seconds? Very good. 30 seconds is that benchmark, which is a differentiator. Deva thought it as 120 seconds is too big, sir. If the VT is more than 30 seconds sustained VT, less than 30 seconds you call it as non-sustained VT. So how best you can make use of these sessions is, you need to once more open your Davidson, Harrison, Enison, and you need to revise the topics which we discussed once for all. That's how you will remember it forever. So if VT causes hypotension, heart failure, you want to give DC cardioversion, how many joules of cardioversion do you deliver in order to manage a case of VT? Who will give the correct answer? Question number 23, one confident answer. Yes. Is it 50 to 100, 100 to 360, 400? What is your answer? Yes. Jasmeet and others, I think they have left for the day. I am not finding an answers from them. Fahima proposes 400. 400 is very big. Heart will burst open. 100 to 360 joules, doctor, is the one which is a typical joulization in case of the VT. Now, you want to manage VT. These are all the drugs used for the management of VT, which is not included among these drugs in the management of the VT. Is it lidocaine or epiduron, procainamide, adenosine? Which one you remembered it in, not in V2, more in SVT? This most of you will correctly answer. Very good. Fahima correctly answered it as adenosine. That's good. Now you have a PSVT. What is the wrong statement about PSVT? Who will give the correct answer, doctor? Does PSVT lead to palpitations? Vagal maneuvers, will it respond? Is it young or old people? Will it lead to wide or narrow QRS? What is wrong about it? Question number 25. I know most of you have correctly answered. Wide means VT. Narrow means, that's good. Deva is confident about wide QRS complex. So doctor, with this we will conclude the today's session. Thanks for a patient participation online across the country, and I wish to see you all tomorrow. We'll make the beginning of neurology in order to quickly finish our schedule. From next week onwards, Saturday subject test, we will have a discussion. Thank you. Not bad.